Well, thank you everybody for joining us this morning. We've got this afternoon, we've got a good program coming. We've just had a really nice conversation about people's accents and how much work we have to do and all kinds of things like that. I'm Lisa Walker. I'm with Hyattsville Aging in Place, and this is the 9th edition of Corridor Conversations for 2024. As you probably know, it's an online series looking at the people and the culture and the heritage that make Route 1 the corridor that it is. This program is a collaboration of the villages, the older adult villages along Route 1 and elsewhere, including Hyattsville Aging in Place, Helping Hands University Park, Neighbors Helping Neighbors College Park, and Exploration on Aging in College Park. We're so pleased to welcome Dr. Trifoglio back. I think she's talked to this group about once a year, actually since the beginning of when Hyattsville Aging in Place started, which was back in 2012. She's going to talk about how to be your best advocate medically first, and then we'll go on to update you on COVID and listeria and various other things that we need to know about. She does want to take your questions, so make sure that that you start thinking them up. Dr. Trifoglio is a board-certified physician in internal medicine and geriatric medicine. She's a member of the American College of Physicians. She's been recognized, as we would agree, for her academic achievement and her community service. She's a part-time clinical instructor at GW University School of Medicine and has been giving presentations, which we're happy about, in the community for more than 30 years. So welcome, Dr. T, and take it away.
Thank you so much. So today there's no PowerPoint, and it's a very casual kind of day. And what I want to explain is that I have some information I'm going to give you, but I'm going to back it up, and Carter is going to kindly post references and information on the Hyattsville Aging in Place website so that you'll have the ability to see what I'm talking about after the fact. And I'm going to post links to information for you so that I don't want you to feel like you have to write things down as we go. But it's a small group, so this is more didactic, more like just give questions and dynamics so that you can chime in and say, well, could you explain that a little more, or I have questions. And I have a couple of small topics prepared, but then also you can go off topic and ask questions that come up. I've done this before. It's sort of like an ask the doc kind of thing. So if there are questions on topics that you're just curious about that are not on my agenda, they can be on your agenda. And we'll move on to those as we move along. One of the things I was asked to start with was how to be your own best advocate. And I think right now, medicine is having a lot of challenges, and I have always practiced with the model of come and be with me, and I'm your, they call us primary care, but I'm your primary internist, and I try to help people navigate the healthcare world. But that's not how the structure of healthcare is moving along, and a lot of people don't have my kind of doctor to anchor them, and you have to go through and go forth and be an advocate for yourself. So you're going to go interface with specialists and with other doctors or with new primary doctors, or go to a doc in the box or the hospital. And so I want to give you sort of a list of things that I want you to have with you when you go, because this is what the medical world needs you to have with you. And so how to be your own best advocate. And a lot of this stuff you already know, but I'm just going to sort of put it together. This is what we're looking for when you come in. The first thing is your list of allergies. What are things that you're allergic to? And an allergy is something that you have a bad reaction to, like hives, or you can't breathe. And intolerance is something that makes you like nauseated. So if you're allergic to codeine, you're going to break out in hives. If it makes you vomit or get nauseated, that would be an intolerance. So bring the list and explain what your reaction was so we can sort it out. People who get nauseated with codeine might be able to handle Percocet. People who have hives or can't breathe with codeine, we're not going to give you the Percocet. So your list of allergies and what happens. And also food allergies. People who are allergic to shellfish, we might be hesitant to give them IV contrast because of the iodine. So food allergies are important as well. Your list of medications. What are you taking? How often are you taking it? How long have you been taking it? And for what are you taking it? And we all know that the list of medications is partially prescribed, and we know there are over-the-counter medicines. These are just as important. And we need to know your list of supplements, things that you are taking that are in little bottles, but that you've just decided to do. They interact, and they can have an impact. We need to know what they are. So put them in that order: prescriptions, over-the-counter, supplements. Through the years, we all accumulated a list of medical diagnoses. I need to know what they are, even if it was in the past. But if you have high blood pressure, if your cholesterol is controlled because you're on a good medicine, you still have high cholesterol. It becomes high cholesterol that is controlled. If you have diabetes, heart disease, if you had a heart attack 10 years ago, you still are considered to have heart disease. You can't say, well, that was in the past, I don't need to mention it. So your list of medical diagnoses, your list of surgeries, and we need to know this. So if you come in, even though you were a kid when you had your appendectomy, if you're having right lower quadrant pain, but you had your appendix taken out as a kid, that's important for us to understand. If you had a hysterectomy, ladies, did they take your ovaries out? That matters also. We want to know what went on in your body in the past. So that's important for us to know. Family history matters. As you get older, it's not as important when you're young. If you had breast cancer in the family at age 30, we want to know that. But as you get older, we still need to know heart disease, cancers, diabetes, and anything unusual. If 6 family members had pancreatic cancer, that's something that's going to trigger in our minds.
Yeah.
Question?
No, that was just me commenting. Ooh.
Ooh. Yes. Now, social history. People sometimes get angry when we ask these social questions, like we're being nosy. And the truth is we are nosy, but we're nosy for a reason. We want to know, are you smoking or have you smoked in the past? People who smoked in the past are higher risk for lung cancer the rest of their lives. So we need to know if you were a smoker. We need to know how much you are really drinking, how much alcohol. And we want you to tell the truth because it just helps us to shape what are your risk factors, what's going on in your liver, what's going on, how does it interact with your medication. We need to know your occupation and what you are high risk for. And sometimes we need to know what your husband's occupation was. If you just tell me you're a housewife, sometimes we've seen people with asbestosis because they cleaned their husband's laundry and he was the one who was exposed to the asbestos, and he came home and they picked up the laundry every day and took it to the wash, and the wife inhaled the asbestos fibers and she ended up with the mesothelioma. So it's not enough to just say, well, I was just a housewife. But if you know that your husband worked in the coal mines or your husband was an asbestos worker, that's important. I'm not looking for just what you did, but what you were at risk for. We also want to know if you use any drugs. So we know about cocaine and we worry about methamphetamines, but also right now marijuana is legal. And a lot of people are doing cannabis. And what we're finding is it has all sorts of side effects and it has a lot of implication for interaction with other medication. And it has not been studied. It's been a class 1 drug. What that means is that they haven't done enough medical information studies. So we're learning, and doctors try to communicate with each other to help. So for example, our colleagues in Colorado have found that people who were in auto accidents, who were daily cannabis users, either eating or inhaling, started to wake up in the middle of surgery when they had auto accidents and they broke a leg. And it turns out that cannabis accelerates the way your body makes enzymes, and that eats up anesthesia. So that I want to know if you're doing daily cannabis, say you come for a pre-op, so I can tell you, please don't do that for 2 to 3 weeks prior to your surgery. People think it's about judgment. It's about caring for you. So we want to know when we're doing a social history about drugs, alcohol, smoking, all of these things so we can best guide you. These are all go on the list. people think it's a checklist, but it's putting together the whole history. So that's this information you're going to bring. You're going to go through whatever the problem is. You want to describe the problem of what you're worried about, how long you've had it, what part of the body, what are the trigger factors, what are your worries, what are your fears, and hopefully they're going to come up with a treatment plan. And the number one responsibility you have is to understand that treatment plan. What has been prescribed, what medication, how do you take it, what x-rays are required, are you going to have to go for home health, do you need physical therapy, where are you going to get it, do you understand it, ask questions. Do you have a wound? How are you going to take care of the wound? How does it get cleansed? Where are you going to get the dressings from? Who is going to check it? Do you have to have sutures removed? Do you need to monitor your blood pressure? If we ask you to check your weight, oftentimes it's for congestive heart failure. We're worried about fluid balance. We're not worried that you're eating too many potato chips. So monitor your weight and tell them, I gained 3 pounds, I'm worried about my fluid. That will often head off a congestive heart failure crisis. We're also monitoring pulse oximeters. If they ask you about monitoring your oxygen level, this has really become a thing after COVID. Understand how it works. Understand your hand has to be warm. Understand what you're reading and when to call for help. The other thing is, it can be complicated. And sometimes you might want to bring an advocate with you. So I had a patient yesterday, and I know that I got a preliminary report from her oncologist. I know there's going to be a complicated conversation. I said, you need to make an appointment to see her to go over this. Bring an advocate with you, because whatever this conversation is going to be, it's going to be confusing. Bring someone with you. So that was my first little summary, and now I want to open it up to questions. Was that too much? Questions, comments?
I would just say that I always think ahead of time about what I'm going to say when I come and see my doctor, and then I don't write down a list and I totally forget it. So I've finally decided, I really need to write this down on a list, just like I'm going shopping.
Right, write the list. It's very helpful. But also, one of the things we're finding is people write a list and they preliminarily go shopping at Dr. Google, and then they come and tell me the diagnosis. I want you to write the list of the symptoms and don't come in with a preformed idea. Or don't go to the specialist and say, I'm coming in because I want you to do my peripheral artery testing. I want you to do my colonoscopy when they're having GI symptoms. Maybe what they need is a Helicobacter pylori test. Your job is to bring the symptoms and let us work through it. Okay? I want people to tell me their story, and then I can help them to help reach the diagnosis. And sometimes what I want is not what the patient wants, and we always try to navigate it and work together. But if you come in with preformed conception, this is what I want, it can be hard sometimes to get to the right place. Although I want to address your concerns. Does that help? Am I overwhelming you?
No, that was good. I thought it was good. But there's a question on the chat line. What about mental illness diagnoses? In my experience, many specialists do not know anything about it or care to hear about it. They think it has nothing to do with their treatments. How do you tell and construct sort of a second question. How do you tell and construct a story in 10 to 20 minutes, the max even for specialists?
It's a big hardship that we don't have enough time with patients, and I obviously take longer than that because it's necessary. Mental illness is interwoven, and you have to get this together. Mental illness impacts our ability to handle information. It impacts our ability to respond to therapy, and it can make it hard to reach a diagnosis. So I need to know what the mental illnesses are. Have you had a history of depression? Have you had a history of bipolar? Do you have an anxiety disorder? Do you have fears? What is going on? What medications are you on? And are you taking those for mental illness? So what you want to do if you have a mental illness is to figure out how can you summarize it and how can you present it so that in a short period of time you can at least give some information to the treating doctor. I don't, go ahead, was there more?
I'm sorry, she just had a follow-up, but that
Go ahead.
says, but the specialists show no interest in hearing about it.
Right, so somehow you have to
Yeah.
convey, this is important for you to know because, okay, I might have trouble, like where some people have dyslexia, I have trouble handling information, so you need to give me a little more time or more of a handout. Or I have trouble with fear, so it's going to make it harder for me to reach a decision, or this makes it interfere with my ability to reach a decision. I can't make decisions easily because I have. Whatever it is that you are dealing with, you have to explain to the specialist because they're not well trained. They don't have enough training to help them understand that it's going to impact your ability to respond to their treatment plan. They might say to you, you need to do A, B, C, and D, and E. And then all of a sudden, this poor person who has other mental issues is like a deer in the headlights, and they're not going to be able to move forward. But the specialist is going to think they're, quote, non-compliant. And so they're going to be at crossroads. And somehow this person who carries this burden of mental illness has to express what's going on so they can reach some sort of working relationship. So being self-aware and somehow being able to communicate that and somehow insisting, and sometimes that's where you need to bring an advocate. Stop, doctor, wait. You don't understand. This is what the issue is. She has a problem here. You have to help us overcome this. And an advocate sometimes helps a third person in the room.
Okay. Anybody else?
All right, so I'm going to move on to my next topic. And if I'm moving too fast or...
Okay, 1 second. I'm sorry. If there's another follow-up. I appreciate your advice, but that has never been my experience. I even brought a medical doctor with me as an advocate.
Oh,
Time for a new doctor. Right?
Time for a new doctor, right, okay. So I have, sometimes when I have patients who are, I don't want to use the word difficult, it's not the right word, but who are challenging because they have mental health issues, I will call the doctor myself, the specialist, and say, this is what the issue is. And if, this is how I'm handling it, and this is what I'm doing. But I have specialists, I know who they are, and I know who's going to work with them, and I know who's not going to work with them. And I will also prep my patients. And sometimes I say, look, go see this person. They have terrible bedside manner, but you only need them to do this, this, and this, and this. And this is how I want you to handle it. And I'll prep them. And sometimes I have to use somebody who's just, he's like a neurosurgeon and he's got a little Asperger's himself. So I have to prep my patient to do what has to be done. But most of the time I will hand select the patients and the doctors and try to find a good match. I one time had a patient and she had breast cancer and she has terrible mental illness and she's paralyzed by decision making. And I sent her to Baltimore to a breast surgeon I knew could handle her. And she did a beautiful job. It took her 9 months to get her lumpectomy, 9 months till she could bring herself to get the procedure. Okay.
Yeah.
All right. Everybody, I had like 7 breast cancer patients who were already finished their radiation before this woman actually made it into the OR. But she made it and she got her lumpectomy. Okay. But she was paralyzed by this inability to make a decision.
Okay.
Okay.
Yeah, that person now gets it, she said. It's a key. The key is a good primary / internist. And then there's another question. Oh, the questions are starting to pop up. Okay. If you feel fine and haven't had any changes in meds, etc., do you need a yearly physical?
Absolutely, yes. And there's a lot of debate about this out there. And I think it's a very unfortunate conclusion that social media has come to, that an annual physical doesn't matter. First of all, when you are getting together with your doctor for once a year, there's a chance for you to ask questions about minor things that might not turn out to be minor. There might be a chance for the doctor to say, look, there's certain things that are going on in the medical world. We want to update you. Like one of the topics today we're going to talk about is whooping cough. There's a whooping cough outbreak. And I'm telling people I want you to get your Tdap vaccine. So I'm asking people, when was your last tetanus shot? We need to coordinate it with pertussis. That's something that I don't often talk about. I haven't been pushing that, but right now I am because we have this outbreak. So there are things in the medical world that are going on. But also, you come in and you see me, and I ask how you are, and we talk, and I go over it. I put a hand on you. I listen to you. I cannot tell you how many times I put a stethoscope on the chest of a 78-year-old, and I hear atrial fibrillation. And just hearing it before they have their stroke, that means I can direct their care and save them from having a stroke. So therefore, doing an exam, talking to the patient, hearing small concerns that might turn out to be bigger concerns later matters. But there's also something else. They come in, they see me, they remember who I am, we reestablish a connection. That means in 6 months when the woman finds a lump, when something happens and the guy has the chest pain, they know who I am, they're not afraid. They hopefully feel that they know that if they have a concern, I'm going to address it. The barrier to care is down. And they feel that they can call and say, can I come see you? I'm worried. That is worth its weight in gold. And then when they come in, we're not catching up after 3 years that I haven't seen them. And they're not afraid of me. They're not afraid of the office. They walk in and it's feeling a comfortable place. That is worth its weight in gold.
Okay. Just sort of a follow-up from someone else. Is that annual physical in addition to Medicare annual visit?
The Medicare annual visit is a little crazy thing, okay? That is supposed to ask you about your medicines, it's, to me, part of my physical. It's what I've been doing all these years before Medicare defined it. What are your medications? What are your allergies updated? Are your vaccines up to date? Are you having any cognitive issues? Are you depressed? But also, the physical should include a review of your medical concerns, and it should include what we call medically the laying on of hands. It should include a physical assessment. Okay, the Medicare Wellness has no physical assessment and no ability to address any medical concerns. So to me, it is a very incomplete thing. Okay, so I do it simultaneous with a visit. Okay, because I don't think it should be separate. But that's my personal decision.
Okay. New question. When a person has multiple doctors, specialists, when a person has cancer, who should be the lead doctor? Do you have a recommendation for that? Okay,
so what happens, like, for me is it depends on really the circumstances. I am a primary internist geriatrician, and most of my patients have been with me for 20, 30 years. So I am always the anchor. But I have some patients who have some very complicated things. Like I have a lady and she has this terrible uterine myosarcoma that metastasized. So she's seeing the oncologist like every 2 weeks. He's really the de facto lead. However, he's very good about making sure that I get the reports. So she continues to see me every 2 to 3 months and make sure that the other things are addressed, that she has a thyroid issue, just some other things. But he's got the lead because when she's dehydrated, he's hydrating her. And when things are not going well, he's taking care of it because her main function right now is staying alive and he's keeping her alive. So in this setting, the oncologist is the main lead. And I have some people who have terrible rheumatoid arthritis and they're on these monoclonal antibody therapies, and they might be also on methotrexate. And then basically the rheumatologist is taking the lead because of the complexity of their medication. But I would probably see them, I would still see them, and I take care of some of the other things. Maybe it's their cholesterol medication. Maybe it's monitoring their mental status. Maybe it's supporting them if they need physical therapy. So if they're on a complex regimen, then the specialist responsible for that might take the lead. If they are somebody who they're on a stable regimen, it falls to me. But also, when they see 6 or 7 doctors, they should always see me, because weaving it together is part of my skill. When somebody comes in and they're on 17 drugs, I'm the only one who knows all 17. And I'm the one who can say, you know what? The fact that you're on the naproxen and the GI doctor has you on Nexium, you got to get off the naproxen or the Nexium's never going to work. And they don't know that all of them are together.
Okay. Please repeat the latest things that we need to know about. That is, what medical conditions are rampant?
Okay, so this is the thing that Lisa and I were talking about. There's a couple of things going on that are sort of new in the community. So I'm going to start with what I just mentioned briefly, and that is that we're having a whooping cough outbreak. That's pertussis. And so what's going on, we have a lot of stuff with anti-vaxxers. And so the children are not getting vaccinated adequately for DPT, which they changed the initials and now they call it Tdap. And that they just changed the order of the letters, but we all knew it as DPT, tetanus, diphtheria, and pertussis. And the babies are supposed to get it at 2, 4, and 6 months, and then they're supposed to get one like in kindergarten, and then they get another one at age 10. But what happened is they stopped vaccinating, and we lost herd immunity. And now pertussis is rising. I have some numbers for you. Prior to the year 2000, we had about 3,000 cases a year. But this year, we've had 18,500 cases so far. It's up pretty dramatically. And the problem with pertussis is it's a whooping cough. And you whoop, like for 3 to 4 months. Nobody wants that. Now, most of you have had it as a kid because there was no vaccine when you were children. However, your immunity wanes over time, so you're at risk to get this whooping cough. Babies, their symptoms sometimes is apnea. Apnea means you stop breathing, and the babies die. And a lot of times, a grandma might get it, and they have a cough, and they feel like, oh, it's been 2 weeks, I'm probably okay. They go see the baby, and they kill the baby. So we really are trying to get the adults to get vaccinated to reduce the amount of pertussis in the community. So we're asking all the adults to please update your Tdap and get this vaccine and try to reduce the amount of pertussis in the community and try to regain herd immunity. So this is a big issue for everybody, but it's a problem. We don't want the adults to get sick, and we don't want the children, the babies, to die. And they get it at 2, 4, and 6 months. They're not immune until they're 6 months of age. So that's one of the things. I did see one of the chat things go by. RSV, respiratory syncytial virus, is a virus that seems to be on the rise since we are unmasked from COVID. Respiratory syncytial virus, RSV. That shot seems to be one, and at the moment, you don't have to repeat it. I suspect they're going to turn that into like an every 5-year thing, but I don't know. At the moment, if you get one, you're okay. And there are 3 vaccines that are approved. GlaxoSmithKline makes one, Moderna makes one, and Pfizer makes one. Any of the 3 are approved, and they all work. So you should get one. And the thing about RSV, though, is it's age 75 and above, or it's age 60 and above if you are emphysema or immunocompromised. Originally, when it came out, they said, I think everybody's 65 and above, but they changed that. It's 75 and above, or if you're immunocompromised. And if you got one last year, you don't have to get it this year.
So how about you want to go back to your list, and then we'll pick up with questions.
Right, so so the whooping cough was on my list. The other thing is, let's just take the COVID out and talk about that for a minute. COVID never went away. COVID is constantly mutating. And I think that what people do not understand is that COVID is a coronavirus, right? It's a coronavirus that causes adult respiratory distress syndrome. Common cold is caused by coronaviruses. There are 3 coronaviruses that cause common colds. And we all keep getting colds, right? We don't get immune to coronaviruses. Coronaviruses mutate. And what we are hoping is that sooner or later, COVID mutates to something that we can handle. But it hasn't mutated to that yet. It's continuing to mutate, but it's continuing to invade the deep tissues. So what we're finding is we have, well, in the winter, we still had 2,000 patients a week die of COVID this last winter. This summer, it was about 600 to 700 a week died of COVID. So I'm raising my own hand. What happens is, if you get vaccinated, you need to get vaccinated every 6 months if you're age 65 and above. And we knew this in the medical community, but somehow this is not getting across to the general community. 6 months, every 6 months you need a vaccine. And what they're doing is they are changing the vaccine to try to keep up with the mutations. Currently we have, I think it's called, it's Omicron K3 1.1 was the most common strain. But right now there's been a little bit of a race with Omicron XEC. And XEC is sort of a blend of the K3.1 with another K3. And so we're finding that XEC is so contagious that it's overtaking it very rapidly. And that's the most contagious strain we've seen yet. And that's what's rising right now. But the current vaccine that just came out will cover it, and you should get it. And people are all like, how many vaccines should I have had? And should I catch up? No, just get the vaccine. And if you skip the May vaccine, get this one now. If you get COVID, you can't get a vaccine for 3 months because the COVID that you got will impair your response to the vaccine. If you got a vaccine and you were late, let's say you got it in June, 4 months, and then you can get the vaccine. Okay, so about every 6 months, but a minimum of 4 months between the vaccines. The other thing is, if you want to have maximum immunity, let's suppose you're going to a wedding or you're traveling or whatever, do it about 2 to 3 weeks prior to your big event or prior to your travel, so you have maximum immunity. But COVID is still causing all sorts of problems. So they just came out with a study that showed that after you have COVID, especially people younger, 40 to 65, heart attack and stroke very common afterwards for 3 years. 3 years, higher risk of heart attack and stroke. And the National Health Service in Britain, they did autopsies on COVID patients, and they found viral load in heart, brain, kidneys, and lung. This is a bug that gets in deep. The younger people are doing pretty well. Their immune system is working better, and they're getting it, and they're getting rid of it. But the older patients, it's invading. So what I'm asking my older patients to do is to be self-aware, to keep up with their vaccines, and to check the COVID map. You know, we do wastewater studies. I don't know, are you guys aware of the wastewater studies? But what that does is the CDC will check, let's back up. Everybody who has COVID, when they go to the bathroom, it comes out in the stool. And they're testing the sewer, and they can tell how much COVID is in the community. And they're publishing that data. So in the summer, our COVID map was sky high. It's a blue map, actually, and it was dark blue. Dark like my blouse, okay? This was the COVID map all summer. Now, it's a little bit lighter, okay? It's more of a sky blue right now, which is nice, but I still had 6 people on Monday get COVID, okay? So it's not gone, but it's lighter blue. And again, that's one of the links you're going to have, is how to look at the wastewater map. If the wastewater map is high, wear a mask when you go to the supermarket. Don't be putting yourself at risk for no reason. Stop eating in the restaurant. Go back to takeout, meeting with your friends, and test before you gather, okay? If you're going to have friends come over and the COVID map is blue, then all of you just do the test so that you don't have an asymptomatic person bring COVID into your group. If you do these things, you won't get COVID. And if you don't do these things, you'll be calling me and saying, hey, could I have a dose of Paxlovid, please? Okay, we can manage this, but people are not managing it, and they're getting very sick. And then the people who are getting sick are taking longer to get better. It's not like it's getting easier. I've had some very sick patients.
A question here. If you're not 75, but you have asthma, should you get the RSV shot?
Yes, because that's immunocompromised, yes.
Okay.
Mm-hmm.
Flu shot and COVID same time or close together?
Okay, so you can get the flu shot and the COVID shot together. Some of my patients have not felt good after that, and they prefer to separate it, so that's a personal choice, but the immune response is the same. What you can't do is flu shot and RSV together, or the flu shot doesn't work as well. So flu shot and COVID are fine.
Okay.
Okay?
I think, Jean, I think Betty had a question before those
She
about
answered.
RSV,
She answered that.
about the annual, an
Yes,
It's
annual
not
shot for
annual,
RSV.
right?
Yes,
Not
but
annual.
It's one
Dr.
shot for
Teese
now.
noticed it and just answered it.
But I think what's going to happen is over time that you might have to boost that. We just don't know because it's a relatively new shot. I also want to say is get the flu shot, get the flu shot. You know, the other thing is people come out and they say, oh, well, it's only a 30%, whatever. If you get a flu shot every year, it actually reactivates all your old flu shots and it improves your resistance to influenza. So people who get flu shot every year, they do not get flu. Also, it's like the COVID shot. It doesn't always protect you 100%, but it reduces your chances of dying and reduces your chances of being in the hospital. In 2022 to 2023 flu season, 21,000 Americans died of flu, okay? And 390,000 were in the hospital. They don't talk about this stuff. And you know, the bird flu is in the news, okay? I don't know, how many bird flu cases were there? Do you guys know? 27. Okay, 390,000 people were in the hospital with influenza. Nobody gets their flu shot, but the bird flu makes the news every single day. Okay, so we're not getting this information appropriately to people. So please get your flu shots and please get your COVID shots.
Okay.
And a Tdap.
Sorry, one second here. Where did it go? Hello.
To lose the
I just can't. Oh,
chat.
there. Okay, no, I got it now. No. Okay. We answered that. Maybe keep a question.
Yeah, I think they're all
Okay.
answered.
Yeah. Okay. And Carter put the link for the current wastewater viral activity levels on chat. But that'll appear on the video.
I'm going to give you how to get your free COVID tests, covid.gov, flu.gov, and the wastewater. That will be on the link. The links are provided.
Okay. Okay, here's one that's, well, I'll just read it. After hearing you last time, I asked how to get an appointment with you, and the answer was no new patients. So now how can we find a physician as well-trained, experienced, and able to communicate as effectively as you? And thank you.
Yes, call your Congress people why they don't support doctors like me. I was told to be apolitical. Okay, so the reality is that they're not supporting doctors like me, and they, by design, eliminated my field. So like my partner retired, Dr. Turkowitz. Nobody's trained to be us. They're not supporting doctors like us. Right.
But isn't it also true that you do end up opening your practice as you have openings, as you have room?
I have not opened my practice since the beginning of COVID.
Yeah. Okay.
Okay. I think what people are not recognizing is that the administrative burden on us has continued to mushroom. They keep giving us, they call it the tyranny of the shoulds. You should do this, you should do this, you should do this. The pre-authorization burdens. The work of COVID continues even though people are not in the office. And the coordination of care burdens and the number of things. Now we have to do social determinants of health. They expect us to fix anxiety, although we have no psychiatric care. I don't know if you realize that the number of geriatric psychiatrists in the 3 states around us that take Medicare is zero. And yet we are to screen for depression, we are to screen for anxiety, we are now to screen for food insecurity, we are to screen for housing insecurity, we are to screen for all of these things, but we are given zero support. So we get all this information and have no ability to help the patients. Okay, so these are all administrative burdens, unfunded mandates that are put upon doctors like us. And then we are penalized for not fixing the problem. So we can't fix society's ills, but we are given the task and given the responsibility and penalized when we can't make it better. So basically what's going on is the doctors who are like me are walking out, are leaving. The attrition rate is tremendous.
I wonder if you have any guidance though for what other areas of practice in for internists that might have similar kinds of training to you. And I mean, how would we screen for that if we were interviewing new doctors?
Right. So, right. So a lot of people left Dr. Turquoise because they expected I would take them on, but I couldn't. So we gave a list of doctors who we thought would take them, and they had trouble finding doctors.
Bonnie says that last week it was possible to get an appointment in January with the other, maybe the
With
new
Dr.
doctor.
Dr. Schisler is taking a couple of patients. Yeah,
Okay.
he takes 1 or 2 a month, I think.
Hmm.
He's still taking 1 or 2 a month. Mm-hmm.
Are there any good online resources for finding primary internists?
You could check. You could check the American Geriatric Society. You could, I don't really know. Right.
Well,
There are places that advertise that they do geriatrics. They advertise that they do internal medicine, but a lot of times it will be a group of nurse practitioners under a single physician. That's what you will find.
Hmm.
That's by design. This is what was designed. Okay.
Mm-hmm.
I want it to be different. So what I'm trying to do, I mean, I don't get out enough to do this. What I'm trying to do is to try to go teach. If I can teach the medical students and explain to them the value of being a doctor like this, maybe I can direct them. Maybe.
Are you still giving out that list of doctors that you had when Dr. Turquoise retired?
I think Gabby still has it. At my front desk.
Your office, yeah.
My office. Mhm.
Yeah.
She probably still has that.
I just realized that I haven't seen your face, your full face, in how many years now?
5 years. Well,
Yeah.
4.5. We started masking in March of 20.
Yeah.
March of 20. Hmm.
Wow.
Yes, this has been a very long, difficult time.
Yeah.
Especially for the medical field. Yeah. Wow.
We are
Well-
the medical field is having a lot of difficulty. Yes. And I think that the general population is unaware of how the medical field is not supported during this time. I want it to be different. So I don't know. As I say, I'm trying to interact with the young doctors to try to help them come of age.
Okay, here's a whole new topic.
Good.
Any opinions on comparative results at concierge practices?
Those of you who are my patients are getting concierge medicine. You may not realize it, but you
Oh.
are. Concierge medicine promises that you will get half an hour medical appointments and that you will get telephone contact with your physician, 24-hour support, which I have on call 24/7, or you will have a covering physician available and you will have your results called to you when you get them. And that if you need to have contact with a specialist, your doctor will contact that specialist when necessary. Okay, so that's better medicine, but that's what you guys are getting.
So are you, is your practice adding a doctor to take Dr. Turquoise's?
We could not find a doctor to take his place. That's what I'm telling you. There is nobody to replace him. That is what my conversation was. There isn't one available.
Wow.
Right.
Here's another new topic. HIV was once the most rapidly among elders in the DMV, yet doctors seldom ask elders sex-related questions. Your thoughts?
So we
Go
should be
ahead.
asking sexual related questions. Right. So if you are, those questions ought to be asked. And when I ask about social history, that should be given. Patients should be open about that. HIV is now a treatable disease. We often don't ask about HIV as directly, but we see things in the blood work or in the clinical history, and that makes us suspicious of HIV, and then we will go there when necessary. Most of our patients with HIV, that's how we find them, because something comes up in the blood work, and then we'll say, oh, are you at risk? But patients should volunteer when they think they are at risk, so when they're giving a history, that should be included.
And it's not just HIV, it's also other sexually
All the sexually
transmitted.
transmitted, right. And anybody who feels they are at risk for sexually transmitted disease, they should be open about that so we can go forward and test. And you're right, we should be asking about it as part of the history.
Anything else on your list, Dr. T?
Yes, I have one other topic, and that was listeria, because listeria has been in the news. The main focus was, I think it was the Boar's Head factory got contaminated, and a lot of people got sick from liverwurst. But actually, there have been several outbreaks of listeria, and so that's known to contaminate many foods, but it's predominantly, listeria grows in a cold and wet environment, which is a deli. I mean, anywhere that it's cold and wet, you can have it. And it's kind of rare. We only had 768 cases so far, but we had this larger outbreak. Most of the time, it's self-limited. It's nausea, vomiting, diarrhea, and fever, and it could be up to 30 days later. So a lot of times people have it and they don't really attribute it to the potato salad that they got or the fact that they got ham at, Aldi's or something. The problem with soft cheeses too, like brie or unpasteurized milk, which is a fad right now and a big problem. And there was an unpasteurized milk outbreak in California, I think. The other tragedy is pregnant women, it results in the death of the baby. So if you're a pregnant woman and you drink unpasteurized milk or have like a soft cheese and it's contaminated with listeria, it will cause death of the fetus you can be 6, 10, 9, up to 9 months pregnant and lose the baby. So you want to avoid deli things, sliced deli meats, meat spreads like the liverwurst, smoked fish, and unpasteurized soft cheeses and milk. It can also be on leafy greens, mushrooms, cut melons, and raw sprouts. So like if you get like a cut watermelon or cut cantaloupe, and raw sprouts, the little sprouts, you're better off cooking those. And you can't wash it off. It doesn't wash off. Heat kills listeria. So if you get a hot dog, cook the hot dog. And if you have, buy the ham, or if you're going to get deli meats or whatever, buy them that are pre-sliced in a factory and sealed. But even still, you might want to cook it. Don't have it raw, especially if you're worried about the outbreak. Make your own potato salad, make your own egg salad, tuna salad. Those things are all high risk. And right now we're seeing a lot of outbreaks. Now, I don't know if you've been hearing about McDonald's and the onions, because the onions apparently were contaminated with E. coli. Usually it's hamburger. Hamburger is notorious for being contaminated with E. coli. And you can get a lot of different things from E. coli, and E. coli itself can cause a little bit of diarrhea, but there's this sugar E. coli that can cause serious illness and death. And it's usually known in burgers because that can be multiple cows get combined into a single burger. But if you have a farm area that got contaminated without, where there were cows with E. coli, and then the water was used to irrigate that area, then the onions could get contaminated. That's probably what they're going to find at the Taylor Farms. I don't know this yet. I don't think they've really identified that, but it seems like this crop of onions got contaminated with the E. coli, and it's the sugar E. coli, and that's the one that kills people. So those onions all got recalled, but they were served raw, and that's, I think, what the problem was. Cooking kills E. coli, so that protects you. So cooking food. And the other thing is, and I'm going to give you links. You guys probably already know you say food handling, but you don't put meat and then the veggies on the same plate. You wash everything. You wash it all in hot water. You cook your meat to 165 to 170 degrees internally. So cooking your food makes a difference. Stay away from deli things. And if you do get something from the deli, make sure you keep it cold and you eat it right away. Don't leave things out on the counter. Stay away from buffets where everything is out and it's been out for a while and you don't know where it came from. And, so those things will protect you from things like listeria. I just had a patient, though, 2 days ago call me that she ate peanut butter and got sick. And it turns out there was salmonella in the peanut butter. It was Jif.
Yikes.
And Jif has recalled peanut butter for salmonella poisoning. So we're seeing a lot more foodborne illnesses in this country.
Wow. Okay, that's a lot.
So, and basic things, wash your hands, wash your hands, wash your hands,
Yeah.
wash your hands with soap and water. We already talked about this with the COVID, but wash your hands with soap and water. It turns out, norovirus is the virus that makes you nausea, vomiting, diarrhea. That does not go away with hand sanitizer. You have to wash your hands with soap and water. So just frequently washing your hands makes a difference just in terms of protecting yourself from all these things on the surface. On the handout that you'll see, I gave you links to safe food handling, washing your hands, how to choose safer foods to protect yourself from listeria, and the CDC guide to the listeria safety. So just to give you ideas of how to stay safe. I also am going to link to the National Institutes of Health on aging, on all the vaccines that you should be getting as seniors. It seemed like an easier way to read it than some of the other handouts.
Okay, Lisa has a question. This election seems to be stressing everyone out. People are depressed and having more problems. Are you seeing this in your office, and what do you recommend?
It's a bad election, and it's hard, and people are stressed for many different reasons on many different levels. So my advice to people generally is to be aware, watch the news or read the news. And sometimes reading the news is a little easier than watching because the television can be inflammatory, but to do it earlier in the day and then turn it off and not be in these 24-hour news cycles where you're just inundated. And then to try to redirect, to go for a walk outside, to read something, the basis of cognitive behavioral therapy is to redirect your thoughts to a more positive thing, to be thinking about things that are good. I try to remind them we have come through many different difficult times. I think that we are going to make it through. I'm hoping we're going to make it through, but to deal with it on a more positive way, and that, all the bad things, to remember that we have good neighbors, we have good people, and to try to really work towards controlling your emotions. And you can't fix what's going on. You have to look forward and calm it down. But mostly I tell them to turn off the 24-hour news cycle. Don't be staring at MSNBC 24/7 or Fox News or NPR, whatever it is. You've got to calm it down, because otherwise you will just get immersed and it will just rev you up so much. And again, meeting with friends, calming down, walking, those are the kinds of things you have to do. You can't change what's going on, but you can change how you react to it.
Thank you.
Can you please talk about hydration for fascia health to avoid stiffness?
So hydration helps everything. And what happens is after you turn like 75, you lose your thirst mechanism. You don't have a natural thirst. And so you need to be more mindful of hydration. Okay, I like that, Linda. Thank you. She just drank water for us. Water is probably fine. Oh, there you go. So you don't have to drink the electrolyte beverages if you're eating a normal diet, unless you have some other reason. So just, you don't need to do Gatorade or anything like that. Just water is good. If you don't like the taste of water, you could add lemon or lime, or you could put it in the fridge and put a few cucumbers in it and make it refreshing. But water, and I would just say every 2 hours, just drink 4 to 6 ounces of water and just keep it going consistently. That helps the body. It helps the brain. Does it help reduce stiffness? Probably to a degree, but to reduce stiffness, you also need to move. You need to be stretching, you need to be moving, and you need to be getting up and moving around every hour minimum.
Okay. What's your recommendation for mammograms for people who are 70 or older?
Okay, so I'm a geriatrician. The dirty little secret of geriatricians is we guess how old you're going to be, and then we adjust the recommendation. Okay, so if I have a patient who's 65 and is terminally ill, I don't tell her to go get a mammogram. If I have a 65-year-old and she's very demented and she can't stand up and do the little dance, I don't tell her to go get a mammogram, because probably the dementia is going to take her out before any kind of breast cancer is going to develop. But I will do a breast check on her so that if she develops something, we could have a family discussion about what we would do. But certainly if I have somebody who's demented, who can't stand up, she's not going to be able to get through surgery and all that other stuff too. But if I have somebody who's 85, who's dancing and physically vibrant, who I think is going to live another 10 years, she's still getting a mammogram. Okay, there are no strong guidelines. There's no data. There's no evidence. There are no placebo-controlled double-blind studies that tell me what I can do. So what we do is we estimate life expectancy and life wellness, and then we base those recommendations on that. Now, sometimes I have people who don't want to go, and what I tell them is the chances of breast cancer rise the older you get, but it's slower growing, and there's a lot more that we can do for an older woman with breast cancer. So I ask them to do a breast exam, and if they feel anything different, to bring it to my attention, and we'll have a conversation about what should be done. So I have 85, 90-year-olds, they don't want to go get smushed anymore, but they are self-aware, they're doing their breast check, and then when they come in, then we can address it and we can take care of it. The 35, 40-year-olds, the perimenopausal women, those are the ones who get jammed. Their estrogen is surging, and they will go from a tiny little lump to dead so fast, they have to do the mammogram. An 85-year-old, there's plenty of time to go from, oh, I feel something, to, okay, let's take a minute. We can get a mammogram. We can get a sonogram. Maybe you only need to do a simple lumpectomy and a Arimidex, and you don't even need radiation. So my recommendation is talk to your doctor and let's see. But there's no hard and fast rule about what time to stop mammograms. Is that a long answer for a quick question?
I can ask, there's a follow-up to that. But I think you've really answered it, which was how often should they have mammograms?
So I slowed them down. Around 80, I do every other year because things are slower growing. So I do every other year with a reminder, be self-aware. Do your breast check, and that's pretty much what I tell them. Every other year is probably okay.
What about pap smears? Oh, I'm sorry.
I'm sorry. Breast checks breasts tend to get less dense as women get older because of the lack of estrogen. They lose some of the breast density, so it's easier to see through the breast. And so they become actually more accurate as they get older. So every other year after age 80 is probably okay, assuming the woman is vibrant and has a good life expectancy.
Okay. What about pap smears after 75?
No, pap smears after 65 are not necessary. It takes a long time to go from cervical abnormality to cervical cancer. So if you have a pap smear every year till 65 and it's normal, you don't need one after 65. However, and also this is your point about sexually transmitted diseases, and this is the conversation I have at that point. If you don't have human papillomavirus and you're in a monogamous relationship and you have not introduced human papillomavirus into the body, you're not going to get cervical cancer because HPV pretty much causes cervical cancer. So if you are either widowed or in the same monogamous relationship, you're not going to get cervical cancer. So you don't need to do the pap smear anymore. So I do tell people if you have a new relationship, you need to tell me so that we could then talk about whether or not you need a pap smear at that point. And if you're in a monogamous relationship at that point, if it's a new relationship but you're monogamous and it's low risk, you don't need the pap smear. But if you're, picked up a new profession, you need to let me know.
Are there any other things that you would look for, like for the pap smear, besides the things you just mentioned?
Yes, so I do tell women, I try to tell me what your symptoms are. I think the summary, though, as people get older, is you need to be self-aware and tell me what your symptoms are. So like ovarian cancer is very hard to determine, but if you're starting to get bloated or having weird lower abdominal symptoms, you need to tell me, and then we'll do a pelvic sonogram. All things are true. One of the things, be your own advocate. Write down what your symptoms are. What are your concerns? I don't know what's going on. You have to tell me. And as people get older, there's a big problem here because Medicare pays for a lot of stuff, and you can go and you can get scanned everywhere, and some doctors will just send you for this and that. I think you should direct it because you could go down the slippery slope of scanning and biopsying and scanning and testing. I think you should live your life and be well and be happy. But if you're having symptoms, if there are things that are concerning, pay attention and then work them up. So if you have pelvic bloating or weird abdominal symptoms, work it up. Ovarian cancer is insidious. If you have change in bowel habits, okay, you're supposed to stop colonoscopy at 80, but if all of a sudden you've got ribbon-thin stool, we're going to do the colonoscopy. So if there are changes in your body, be aware, make your list, bring it in, and let's talk about what needs to be done.
It's a lot of information. It's great. This is great. I know this is like it's been the best in a long time. Does anybody else have any more questions that they want to put in the chat or ask verbally? No? And Dr. T, do you have anything you want to add?
I think that I wish that there were more of me around. That's why I'm hoping at some point to start teaching more. I think this is really important. Yes. But if you can be your own advocate, you can get the care that you need. You might end up with maybe a good nurse practitioner, but maybe another specialist, but they might not be the right specialist, but they could direct you to the correct specialist you need to be. So figuring out a way that you can get the care and that you need. But if you are aware of your own body, if you are aware of what you need to do, and if you can communicate those needs, you will get where you need to be. One thing about medicine, what's interesting I heard is that America does disease really well. We don't do healthcare really well. But if you can figure out what you need and you get a disease, you can get what you need done. You just have to advocate for yourself. And you can.
One observation, or I guess, well, someone asked, hasn't science figured out that they need to figure out how to clone you?
How to clone me?
Yes. That wasn't Mike. That was, all right. I think
I don't think
else
you could
popped
handle
up.
more than one of me.
All right, wait. There's two more. It's okay. Somebody asked if your checklist of information to bring to the doctor appointments will be on the website.
Yes. Mm-hmm.
Yes.
We will
Okay.
post it to the website the same time the video of this is posted, and I will send out the email to everyone who's registered to let them know that it's up.
Okay. A lot of people saying how pleased they are with this conversation we've had. Okay, wait, one more. Let's see. You can say when you want to stop, Dr. T. This has been a wonderful event. Thank you so much. My husband and I are fortunate to be Dr. Schischler's patients.
Oh, good.
What about prostate awareness?
So prostate awareness, the thing about prostate is that so prostate is an interesting field right now. Men who live long enough will get prostate cancer. We have to be careful because we don't want to spend time attacking them, biopsying them, when watchful waiting is the appropriate thing. Many men in their 80s, 90s might get prostate cancer, but they might die of something else later on. On the other hand, we don't want to miss aggressive prostate cancer. So figuring that out can be tricky. So we're not really screening people as much for prostate cancer once they hit 80, 85. On the other hand, we are screening younger. So 40, 45, we're starting to screen for prostate cancer because the young men, just like the young women with breast cancer, they're the ones who get the aggressive prostate cancer generally. Mm-hmm. So we want to take care of prostate cancer correctly, and finding that correct line is shifting, and we're working towards that. On the other hand, prostate enlargement can be a misery for men as they get older. And the good news is we have a lot of new techniques for that. First of all, we have some easy meds like the Tamsulosin or the Flomax works well to help you urinate easier and flow better. And if you need a procedure, they used to just hack away and do a TUR, but now they have these new like green light lasers and different ways of reducing the size of the prostate so that it opens up the way the urethra goes through, and you're able to void much more comfortably. So the urologists have some new tricks up their sleeve to just gently open that up and allow the voiding to happen. So there's better solutions for prostate health in a lot of ways. But finding the right decision, how aggressive to be, that's always a decision that has to be done individually.
Okay, one more maybe, and then we'll let you go. Are nurse practitioners being trained in geriatrics today?
So people are, I don't know what the level of training is. I actually don't know. I don't know. And in all honesty, I'm going to work on finding that out. And I don't know exactly what's going on in the training world. There's a lot of debate and discussion that nobody's being trained in geriatrics. They're all being trained to a degree in internal medicine, and then they all go off and become specialized. And then some people end up doing clinical medicine, but they're not properly trained in geriatrics. And a lot of the geriatricians are just doing research and they're not actually practicing in geriatrics. So I mean, I was blessed. I had really fine geriatric training down at GW, and I've been trained by doing, and the field has changed. It's not been a nurtured field, and it's a big problem. It's a giant problem. Can this be turned around? That's in the medical world. In the geriatric world, that's being debated. Can it be turned around? Can we train? Can we train geriatricians? Can we train geriatric nurse practitioners? Do they want to be trained? I don't know the answers. I don't. And in all honesty, I see that as part of my next phase of life, but I don't know how that's going to unfold.
Okay, thank you. Lisa, do you want to?
Yeah, and
Sum up?
I have one, no, I don't,
No,
I
not
can't
yet, okay.
possibly sum this up. But I do have one last question, which sort of goes along with maybe improper training or maybe bad advice being given. But a friend of mine who had fallen only once, and it wasn't me, I admit that I've fallen recently twice, but who had only fallen once, she's only just 60 years old. She went to her doctor, and her doctor warned her that she needed to be aware of cascading medical problems. And I was like, I don't think so at this age, given the fact that you're healthy. So can you respond to that, or is that, do you know, should we not question what the doctor said?
Right. I mean, I don't know what the
That's
circumstances were, and I don't know what her status is, so I can't really speak to that. We talked about this briefly, but in an older person, a fall can provoke a cascade of events. I don't know if it would pertain to your friend or not. An elderly, frail patient who falls, that can be the beginning of one thing leading to another. And it can, I mean, hip fracture can lead to death, okay? And I had a patient who fell and she got a hairline fracture in her arm, and she ended up with congestive heart failure and then death. So older, frail patients with no reserve, falls can provoke a total decline. So fall prevention is a super important thing, especially for the frail elderly. But a 60-year-old who fell, I mean, I have people, I mean, stuff happens. I mean, you stumble and you fall, or you walk into something, or you don't turn the light on and you have a problem. That doesn't mean that it's the beginning of the end. It means you got to pay attention, and it's a word to the wise kind of thing. So I don't know the circumstances of your friend, so I can't speak to that. So I don't know.
We have a couple more. There are a couple more, Jean.
Yeah, no, I know, I'm looking, yeah. Sounds like we need a foundation to advocate for more geriatric training and more practitioners.
Yes, you need to advocate. And I think that
How do we do that?
I don't know the answer, because the political class doesn't listen to the physicians at all. We are not, we're totally disenfranchised. We don't have it, but the patients might. And I don't know how to tell you to advocate, but they are not supporting geriatrics. They are not supporting physicians. So I don't know how to make that happen. I haven't been able to make it happen. It's 40 years I'm doing this. I can't make it happen.
Maybe we need to talk to AARP about this as well.
Yeah, that's what someone just wrote.
Yeah, they advocate for their own stuff. Okay, they're off on a tangent.
Okay. Oh, now the questions are popping up. Okay, let's see. How should the research side of geriatrics? All of a sudden I can't see it. Is there?
So there is research being done in geriatrics. The American Geriatric Society does stuff. And interestingly, the VA is fabulous at doing research. A lot of COVID research came out of the VA. They were the ones who first, I mean, we've seen terrible things with COVID, but they are the first ones. Like I was seeing patients in their 60s, 6 weeks after COVID, dropping dead. And I'm like, were having like heart attacks and sudden death. And I was seeing that thinking, am I just crazy? And the VA published this data that confirmed, yes, that was a thing with the Delta thing. The pulmonary emboli after COVID. VA had the studies. So the VA has been wonderful about doing geriatric research, and a great number of our geriatricians in the country practice at the VA. That's a protected environment, and that has really forwarded the field of geriatrics. They also do a lot of the wound research. They do a lot of the amputation research. They do a lot of dementia research. The VA has been fabulous. So they are part of where we get a lot of our published studies from. And the big research centers, I mean, you can go to Brigham and Women's, they have a big geriatrics program and they do research. So a lot of the geriatricians, they're not me, because my ability to stay in practice is just so tenuous. So the big geriatricians they're at the research centers. They don't see people, they do research.
Okay. I think covered everything.
Well, does the NIH Institute on Aging address things? And
To
what
a
about
degree. They
Yeah.
sponsor the research around the world, around the country.
And what about the state of Maryland's Office on Aging? I mean, actually, that's something that we could approach.
Okay, so when COVID came out, I called the Department of Aging for Prince George's County, and it wasn't staffed. They had nobody assigned. And I called also Brooks. She had nobody assigned in any of those locations.
I think that's the county, though. The state
countywide.
under the new governor is quite a bit more proactive, so it might be something we
I
should
don't know.
address.
I don't
Yeah.
know. I did meet with one of the delegates, and she very kindly gave me 2 hours of her time, and nothing came of it.
Mm.
So I'm not. What's fascinating to me is Washington, D.C., Marion Barry actually put in amazing programs for the elderly. And if I have patients in the district versus patients here, the district, they take care of their elderly in amazing ways. If they need a ramp to get in and out of the house because they're wheelchair bound, that gets done. If they need an aide 4 hours a day to keep them at home, that gets given. The amount of services that you can get in the district for people who are old, impaired, and frail, it's unbelievable. What I can get done in Maryland is nothing.
Right.
Okay.
So I will just add on to that the DC Department of Aging or Office on Aging also supports all of the organizations like ours, like Hyattsville Aging in Place, like Neighbors, Helping Neighbors in College Park, like Helping Hands University Park. They actually give, I think it's either, Carter will check me on this, it's either $50,000 a year to each village. So it's, it's pretty amazing what's available to them. They support an infrastructure, which is really good, in addition to having programs.
Right.
Yeah.
And this community kind of infrastructure, it makes a difference. Okay.
Right.
And as far as I can tell, Maryland does not have that kind of infrastructure support.
Right.
Okay. It's been very frustrating.
Yeah. Okay.
Let's see. Bonnie wrote something about Jocelyn Melnick.
Pena
our
Melnick, yeah.
State rep is chair of the Health and Government Operations Committee. She listens.
She listens, but does she do?
I don't know. She also represents, I think it's College Park, not our area. It's District 21, whatever that is. Because we're 20, well, Hyattsville's 22. I don't want to say we, but we have a number of districts here. I don't know, we can go a little longer, but Dr. T, you've been wonderful. We're at 3:20. I just have some closing remarks. Are there any last questions that people want to ask?
Okay.
This is great. Thank you. Yes, and we'll all be calling your office to see whether we can get onto your appointment schedule. Thank you all for coming today. We really appreciate it. We really want to have Dr. T come back again in the near future. I just want to say a few things about upcoming events. Our next program for Corridor Conversation is on November 23rd. It'll be Maya Davis and members of the Riversdale staff talking about historically what they've done for holidays at Riversdale, as well as what they have planned for this year. And they have just launched a new program there about the enslaved people who were at Riversdale, and they will share that information as well. So that's on November 23rd, a Saturday at 2 p.m. Just want to mention that Hyattsville Aging in Place fundraiser at Franklin's is on December the 10th from 11 to 9, in other words, all day. And as you know, they will give us 20% of all that's purchased that day if you turn in your receipt. Last thing I want to say is just something about the villages in Prince George's County. There are only 5 of us in Prince George's County, which, support this program. We're always looking for recruits to help older adults in our communities. And Carter's going to include some contact information, but if you went to what's called pgcbc.org and scroll down to the bottom of the page, you can get contact information for each one of the villages if you would be interested in volunteering for them. I know a number of volunteers are already on this program, so you don't have to volunteer a second time, but again, we're always looking for volunteers. And thank you again, Dr. T.
Thank you for having me.
very much. Yeah.
Yeah, that's great.
Thank you.
Mhm.
Be healthy.